we are glad to welcome you to our session today. This is session 8 of the Oxygen Therapy and Critical Care series. So just to remind a few things, so today we are going to be discussing on high flow nasal cannula and non-invasive ventilation, today August 26, 2021. And I would like to send our sincere thanks to Assist International and Stanford Medicine Division of Global Anesthesia and University of New Mexico Health Sciences, Aminokano Teaching Hospital and Project Echo Institute for enabling us to have this session today. And as usual, we are going to have our panelist, Dr. Al-Hassan Datti from Aminokano Teaching Hospital. We're also going to have Dr. Salim Ibrahim Abdullahi from Abubakar Tafawa Balewa University Teaching Hospital. Also, we're going to have Dr. Irene Arinesen Akideno from Irua Specialist Teaching Hospital in Nigeria. We also have with us Dr. Henry Embu from Jos University Teaching Hospital and Dr. Musa Kalamu Suleiman from the John F. Kennedy Memorial Medical Center. So I'm gladly welcome all of you to join. We will be having a French interpretation with us. So for you who would prefer, you can look at the interpretation function at the bottom of your screen as is shown there, and you can click and then you can choose French, and then you will have French interpretation. After sharing this with you, I would like to welcome Dr. Datti to introduce the panelists and begin the session. Dr. Datti, welcome.
Good afternoon, everyone, and welcome to session number 8, which is high flow oxygen therapy and non-invasive positive pressure ventilation. With me, I have the usual great team. I have Dr. Salim Ibrahim Abdullahi, who is a consultant anesthetist at Abubakar Tafawa Balewa Teaching Hospital in Bauchi. We have Dr. Irene Ahideno from Irua Specialist Hospital in from Edo State. And we have Dr. Musa Kalam Suleiman, who is based in John F. Kennedy Memorial Medical Center, Monrovia. And we have Dr. Henry Embu from Jos University Teaching Hospital, Jos, Nigeria. You are all welcome.
Thank you.
So today's session is the case-based discussion to illustrate the high flow oxygen therapy and non-invasive positive pressure ventilation. And as usual, we have our target is to see what are the practice changes that we have to gain from this discussion. Our case discussion will be on the 39-area-old male patient with tachypnea and hypoxemia. Okay, so let's scroll down and let's see the practice change. The practice change objectives, what we need to strive at the end of this discussion is to try and on the high flow oxygen therapy, we need to understand the upper limit of low flow devices. All along we have been discussing about the low flow devices. Then we have to differentiate between how low flow oxygen therapy and high flow oxygen therapy, and understand when to escalate to high flow oxygen therapy. We should be able to list the proposed benefits of high flow oxygen therapy, and we should also be able to list possible complications of high flow oxygen therapy. And we need to understand how to up-titrate, that is to escalate high flow oxygen therapy, and then to understand how to down titrate, that is to de-escalate high flow oxygen therapy. For the non-invasive positive pressure ventilation, we need to be able to list the indications for non-invasive positive pressure ventilation for acute respiratory failure, and we should be able to list proposed benefits of NIPPV, and least possible complications of NIPV. Okay, so let's start. Now we have a case here of Mr. G, who is 39 years old and presents with a 5 days worsening shortness of breath and dry cough. His breathing is harder when he gets up and walks around. That is, he has more dyspnea on exertion. So he has tried to stay in bed and rest. He noticed that his fingers and toes are blue when his breathing is much harder. That is when it's the worst. In his past medical history, he's obese with a BMI of 35. He has a type 2 diabetes mellitus, who is on oral hypoglycemics. And he has had appendectomy when he was 20 years old, that's 19 years ago. He has no allergies. And he works as a house painter. He's divorced and has a 10-year-old son. He does not smoke, but drinks alcohol occasionally. So now the high flow oxygen therapy. Now we need to remember when you're giving high flow oxygen therapy, there are things we need to remember now, because high flow oxygen therapy have the capacity to aerosolize, and therefore we need to remind ourselves of the PPE. That is personal protection equipment. Maybe let's click for more information there before we proceed. All right, so when you click on this important information, material, you can refer to it on the using personal protective equipment, and you have the changes, summary of changes, and then you have who needs the PPE, patients, healthcare personnel, and how to put on or how to don the PPE gear, and so on. So you will find a guide here, a quick reference to do that. Okay, and I think there is a video after this. Okay, fine, let's go. So let's scroll down. So here, the practice change objectives for this section is to understand the upper limit of low flow devices, differentiate between low flow oxygen therapy and high flow oxygen therapy, and to understand when to escalate to high flow oxygen therapy. Now, let me call on Dr. Henry Embu. Are you there?
Yeah, I'm here, Dr. Datti.
Okay, great. So you take us through this section, which there is a quiz there, and then there is a reference there after the for our participants.
Okay, thank you so much. I greet other persons, those on the panel and the panelists and the participants. There's a question on the board. Which low flow oxygen delivery device delivers the highest FiO2? And there are options there: the nasal cannula, simple face mask, nasal catheter, mask with reservoir bag, otherwise known as rebreathing bag, the Venturi mask. So please type your responses in the chat box. Okay, responses have started coming. E, which is Venturi mask. More responses. So far, 1. D, mask with reservoir bag. More responses from, D again. D, that is mask reservoir bag, which is a non-rebreathing mask or bag. D. Okay. All right. Another E coming in, which is the Venturi mask. Okay. I think we can move. I think we just click on the material, the resource that we have, so that we can go on. Okay, thank you. So we have oxygen delivery devices, flows, and concentrations. So we have the nasal prongs, which is used in adults and children, and the flow in liters per minute is 0.5 to 5 liters per minute. Let's move to, and it can give a fractional FiO2, fractional expired 40%. Then we have the nasopharyngeal catheter, usually used in infants and children. The catheter is inserted into the pharynx. In liters per minute is 0.5 to 2 liters per minute. It delivers FiO2 of 45 to 60%. Then we have the face mask, which is the oxygen face mask, the simple face mask. Used in adults and children with a flow rate of 6 to 10 liters per minute and delivers an FiO2 of 44 to 60%. Then we have next, please, the mask with reservoir bag, which is a non-rebreather used in children and adults, delivers 10 to 15 liters per minute and gives an FiO2 of 60 to 95%. And then we have the Venturi mask, also used in children and adults. Delivers 4 to 15 liters per minute and gives an FiO2 of 24 to 60%. So if you scroll down, you set box incubator. Thank you. Can we go back to the presentation? So of course, the link to this material will be available in the chat box. So mask with risk has a flow rate of 5 to 15 liters per minute, as we saw there. So, okay.
Yeah, thank you very much, Henry. You can see obviously D is the answer, right? So D is the answer in this quiz.
Yeah, yes, D is the answer.
Based on the, yeah. So all those who put D, I say this is correct. And then you have the material to always remind yourself. Now let's go to the case update and see. Now, Mr. G has the following vital signs. Temperature was recorded at 38 degrees Celsius. His blood pressure was 107/88, respiratory rate of 28, and the saturation, that's peripheral oxygen saturation, 90% on face mask with the reservoir bag at 50 liters per minute. That is the upper limit of your choice in that quiz. and you are getting 90% of it. So let me call on Dr. Suleiman, if he can hear us, to take us through these vital signs, and then with the questions that follow. Dr. Suleiman?
Okay, thank you very much, Dr. Datti.
Yeah.
Good afternoon to you all, both the panelists and the participants. We have all seen the vital signs of this patient, and I know in our minds some diagnoses must have started coming to our minds. The next thing there is for us to list signs of respiratory distress in adult patients. So please, from the participants, can we start having your responses? List of signs of respiratory distress in adult patients. Okay. We are yet to receive any response. I know we all know them. We always see patients with respiratory distress, patients respiratory diseases. Okay, tachypnea. Good. What else? Cyanosis. Okay, interpolarization. Flaring of alarming sign. Okay, I think we have many other signs. However, let's click and see what they have for us here.
Na je na kai yara gidan kanwata. Ai an gurje hanyar jiya. Ina kika je? Zan shiga na farawa da yara. Okay.
Sound that hello. So please, can we move up? The major signs of respiratory distress. Let's move up. It's important to know the signs of respiratory distress so that we can be able to pick up pulmonary diseases, which are, can be life-threatening most of the times. And the earlier you commence treatment, the better, so that you prevent progression or worsening of the disease. So they said the respiratory rate, which is somebody has mentioned tachypnea. So usually patients have a higher than normal respiratory rate, color changes, which is the cyanosis, bleached coloring of the water, grunting, patient can be making a grunt sound, nose flaring, that's also been mentioned, retractions, which are the intercourse of sorry, I lost my connection, but I have regained it back. Others are sweating, wheezing, body positioning, patients lean forward, and they have difficulty, inability to complete one sentence is a sign of severe respiratory distress. So let's go back to the is being able to see the signs of respiratory. So we have a video here that I believe we will see some of these signs. Video. So please, let's play the video. Hello, sorry, my connection has been poor. As we can see, even there's no audio in the video, but we can see some of the features that we have mentioned. You can see the intercostal recession in the patient, having labored breathing. So let's go back. Okay. The next thing is true or false. High flow nasal cannula is delivered at flow greater than 6 liters per minute. Is it true that when you deliver high flow, oxygen through nasal cannula at this flow rate is considered as high flow nasal cannula oxygenation? That's the question. And we want to know your responses. Is it true or is false? If it's true, we'll see. If it is false, then what is the true answer? So please, your responses before you click on that. Let's let us know what the participants think. I'm expecting some responses in the chat. Well, for the purpose, for the sake of time, since responses are not, maybe we should click and see what they have for them. Can we click the info there? Okay, so this is a picture showing us a setup for high flow nasal cannula oxygen therapy in adults. And as we can see, the flow meter there, it's an oxygen air blender, which is, I believe, a form of compressor, which entrains air in order to give you the oxygen mixture and the FiO2 that you need. And if you look at below, there is a humidifier, and it's to be an active humidifier. As we know, humidification can be passive and active. When it's active, then what it means, either some form of energy is added to it in order to produce the vapor, and most of the times heat. Ultrasound and ultrasonic device to humidify oxygen. In this case, that is being added to it, and then it travels through the nasal cannula, which is tightly fitted to the patient nurse. It is that high flow nasal cannula oxygen therapy generates up to 60 liters per minute. But generally, when we say high flow oxygen therapy, adult press high flow of about 22 liters per minute. So when you are delivering oxygen at a flow rate that's higher, that will be high, and it is be that go back to the main discussion. So let's have this is false, because they said flow is at 6 means so cancer is false.
Dr. Musa, sorry, your network is pretty unstable. We cannot hear you clearly.
Okay, can you hear me now?
Yes, it's better.
Okay, thank you very much. So what I was saying is that from the information we just had now, it's obvious that the answer is false, since in this case scenario, oxygen is being delivered at 6 liters per minute. And we said for it to be considered high flow nasal cannula oxygen therapy, it has to be above the normal flow rate of a patient. And we said at rest, an adult has a flow rate of about 20 to 30 liters per minute, which increases when there is respiratory distress. So in any case, this particular statement here is false. So please, let's play the video below, and I think we will get more information on high flow oxygen therapy.
What is high flow therapy? High flow therapy is when oxygen is being delivered to the patient at a flow rate that meets or exceeds their inspiratory flow demand. What does that mean? Well, did you know that at rest, the average adult will inhale at a speed of 20 to 30 liters per minute? In other words, if someone was standing next to you right now with a radar gun pointing at your nose, capable of measuring how fast you're inhaling while you're relaxed, the speed at which you inhale would be at around 20 to 30 liters per minute. So high flow therapy should be capable of matching the inspiratory flow, or even exceeding it. If an oxygen device delivers less than the patient's inspiratory flow, then the delivery is called low flow. So because the average adult who is at rest inhales at a speed or flow of 20 to 30 liters per minute, a high flow device should be capable of delivering at least that much. Now, in order for this high flow of oxygen to be comfortable to the patient, the oxygen should be heated and humidified to maximize patient tolerance and comfort. And sometimes you'll see high flow therapy described as heated and humidified high flow oxygen therapy, or heated and humidified high flow nasal cannula, or to keep it short, it may be referred to as HHFNC or HFNC, or even HFOT or HFT, or some other variation of that. More recently, Vapotherm has chosen to refer to their heated high flow therapy as HVNI. They've even tried to describe HVNI as mask-free NIV, but don't get thrown off. On the FDA's website, it clearly identifies their device type as high-flow humidified oxygen delivery device. Now, like other high-flow devices, they deliver a high flow of oxygen, and it is heated and humidified to help meet patient comfort and tolerance. And some devices, like Vapotherm's Precision Flow, go up to 40 liters per minute. Others, like the FNP Airvo 2, go up to 60 liters of flow, while still others can go even higher, because at the end of the day, we're just trying to meet the inspiratory flow of a patient And when that patient is in respiratory distress, that inspiratory demand can be as high as 100 liters per minute. Yikes. So, should high flow therapy be a replacement to other forms of therapy like non-invasive ventilation? The answer? Absolutely not. High flow oxygen delivers just that, a high flow of oxygen. But sometimes patients have issues with CO2 or ventilation, and not just issues with O2 or oxygenation. NIV is effective for both oxygenation and ventilation. This is why HFT and NIV are often used together on some patients in a complementary fashion. For example, some patients may be on high flow therapy but require more support. Clinicians sometimes escalate to NIV to prevent, if possible, intubation and invasive mechanical ventilation. And if a patient is on NIV and can tolerate short breaks, clinicians sometimes switch to high flow therapy to allow the patient to have that temporary break from NIV where they can eat, talk with their relatives, take an oral medication. You get the idea. In fact, in a Vapotherm-sponsored study, there were 104 patients who presented to the ER in respiratory distress, and they were initially placed on high-flow oxygen. Of those 104 patients, unfortunately, 27 of them failed, and of the 27, 4 were immediately intubated. But the other 23 patients were switched from the high-flow oxygen to NIV. And of the 23 patients who failed with high-flow oxygen and were switched to NIV, 20 of them improved and did not need further escalation to intubation. In fact, in another study, patients at high risk of post-extubation failure were placed in one of two categories. The first category was high-flow therapy only, and the other group allowed for both NIV and high-flow therapy. Now, the patients that went on both NIV and HFT had a significantly lower rate of reintubation versus the group that went on HFT only. So don't get confused. HFT is definitely not mask-free NIV, but it is a great tool to treat patients with oxygenation issues who are in respiratory distress. So, just a quick final summary on high flow therapy. High flow oxygen therapy usually delivers oxygen at a flow rate equal to or higher than the patient's actual inspiratory flow rate. It should be heated and humidified for patient tolerance. And depending on the flow rate and the seal around the nose and mouth, high flow oxygen may create a CPAP effect, although we don't know exactly how much. It also may wash out some CO2 that is in the upper airway, which is often referred to as CO2 dead space washout. But again, we don't know exactly how much. So that's your quick introduction to high flow therapy.
Yeah, thank you. Thank you very much, Dr. Suleiman. Now, what we have seen on the video and what Dr. Suleiman was able to explain to all of us is about the high flow nasal cannula and then the device and how to use it. And the basis of the high flow oxygen therapy, which the summary is that you need to be able to generate a flow equal to what the patient should be getting at rest, which is at least 30 liters per minute. And we've seen that with the device, it can generate up to 60 liters per minute. So you need to have the device to be able to do that. Now, Dr. Salim, get ready for this bit, this segment. So our patient, despite receiving oxygen by mask with the reservoir bag, which we've seen, we agreed that among the other devices that it has the highest FiO2, he continues to have a fast rate, that is his tachypneic. His respiratory rate is now 36 per minute. And the SpO2 deteriorated to 88%. So the bedside provider, which could be the nurse or a doctor, decides to take him on high flow oxygen therapy, rather. So here, what we need to gain from this segment is to be able to list the proposed benefits of high flow oxygen therapy, to list the possible complications of high flow therapy, oxygen therapy, and to understand how to escalate the high flow oxygen therapy and also how to de-escalate the oxygen flow therapy. So Dr. Salim, if you are available, you can take us through this segment. Thank you.
Okay, thank you, Dr. Datti, and good afternoon all. So we have the quiz before us on the screen, and let's start with the first one. What are to list the proposed benefits of high flow oxygen therapy? We have 30 seconds to provide answers in the chat box. No response yet. We have about 25 seconds so that we can proceed. What are some of the benefits of high flow oxygen therapy? No responses yet. Okay, we have one response: oxygenation, some CPAP effect, and then convenient. Okay. Okay, we have less than 30 seconds to proceed. Okay, another response: ensuring a fast oxygen delivery. Yes, it improves oxygenation. Okay, so I think, thank you for the responses. And then the last one that just came washes out carbon dioxide. Okay, so the high flow nasal cannula is an oxygenation strategy used to avoid intubation. So when compared to the conventional oxygen delivery systems, one like as we get from the responses, we have enhanced patient comfort. So the patient gets more comfortable with it, and then because of the increased humidification of secretions, it facilitates expectoration. Because one of the parameters that need to be set on the high flow nasal cannula, apart from the FiO2, you equally need to set the temperature. And it is advisable when you set the temperature, you don't immediately connect the patient to the device immediately after turning it on. You allowed the device to reach the humidifier to reach the already preset temperature, so that will enhance patient comfort. Because otherwise, by the time you just put the patient on, then you are delivering a cold gas and at a very high flow rate, which will not be comfortable to the patient, and the patient may even reject it. So that is also one of these benefits. And then another benefit that has been rightly mentioned is carbon dioxide washout, because it washes out the nasopharyngeal dead space, which improves the efficiency of ventilation. So there is carbon dioxide washout. And then there is a provision of a small positive airway pressure effect, which somebody mentioned as CPAP. But the disadvantage of this pressure cannot be measured. And then the high flow, one other advantage, the high flow rate minimizes the entrainment of air. So there is a resource material there, which we can get most of these benefits and even more to read at our own leisure time. So let's click on the resource material. Okay, so you can see heated and humidify high flow nasal oxygen in adults. Get practical considerations and potential applications. So when you go through this material, you can get all the benefits that we mentioned and then even more. So let's thank you. Let's take the second quiz, which asks the list the possible complications of high flow oxygen therapy. So this one too, we have 30 seconds to respond with the answers in the chat box. List the possible complications of high flow oxygen therapy. So the link to that material has been posted on the chat box, so you can access it later. So we have 30 seconds to respond with the answers for this. Okay, somebody? Okay, the answers are coming. One, oxygen toxicity. Okay. Breath stacking. Okay. Barotrauma. Okay. Okay, abdominal distension. Okay, aspiration. Okay, so thank you for the responses. Yes, there are complications associated with high flow nasal cannula, but these complications, they are rare. And like you have provided in the answers, you have abdominal distension. Yes, because of the high flow rate, there is risk for abdominal distension. And by the time there is abdominal distension, then that patient is being predisposed to aspiration. So the patient can regurgitate and then subsequently aspirate because it is not an invasive therapy, so the airway is unprotected. So depending on the level of consciousness of the patient might aspirate. And then rarely we can have barotrauma, which can also happen. But like I said, these complications, they are very rare. So there is also a link for resource materials that we can review that provides the contraindications and complications. So this one that we just mentioned are the complications. So what are the contraindications? So the contraindications, they are usually abnormalities or surgery of the face, nose or airway that will not allow an appropriate fitting nasal cannula, because that is one of the requirements. The nasal cannula has to snugly fit into the nares and then held in place by a head strap. So where this cannot be achieved, then the high flow oxygen therapy too is not possible. So these are some of the contraindications. So we can click on the resource material on the link so that we get some of these contraindications and complications.
Yeah, thank you very much, Dr. Salim.
Okay.
I don't know, Kevin, your screen, is it?
Sorry, Dr. Datti, I encountered a problem, but I'm trying to reshare the screen again.
So before you do that, just to recap on what Dr. Salim explained to us, the complications of high flow nasal cannula, I mean giving a high flow oxygen therapy through the cannula. Abdominal distension is one complication you can encounter, and simply because you are administering oxygen at high flow, so air getting into the stomach and then distending the stomach. This you should know the mechanism. And then you can have aspiration, because if it's distended, the stomach is distended, especially those patients at risk of regurgitation and aspiration, you can have aspiration. This issue you should be aware of. And you can also have barotrauma. You know, there are patients with airway diseases that you can easily cause barotrauma. And then, of course, the contraindication, the main contraindication there, if there is trauma to the face or there has been a surgery to the face that alter the anatomy of which you cannot conveniently fit this in cannula. So this therapy at this point is contraindicated. So we wait for, I don't know, Kevin, you're still trying to, let me see if I can. Sorry, it's having some technical issues sharing this. So,
Dr. Datti, is it
yeah.
possible, could you share the LRC from your screen?
Okay,
My computer just crashed and I had to switch to the phone, sorry.
Okay, let me see. If you enable me.
Okay, please, Echo India team, allow Dr. Datti to share the screen.
Yes, yes, just give us a second.
Please, as you come in, try to unmute especially if you have a background noise, so that
You have the forward access.
okay. Have you enabled me? Okay, great. So let me see. All right. So here we are. Now we just finished this segment, which Dr. Salim explained to us the benefit and also the complications. So as usual, you will have this useful resource in UpToDate where you can find all these things. All these things that we are discussing here, when you register at the LRC site, you will find them and you can download them for your reference. Now, I call on Dr. Irene. I don't know if you're there. Are you with us,
Yes,
Irene?
I'm here.
Sorry for
I
that.
am.
Yeah, we soon come into the area where I'm sure you have lots of experience there in the NIPP. Now you can take us through this segment, please. There is a quiz there. Can you see my screen?
Thank you very much for that. Good afternoon, everyone. Welcome on board. I'm going to be taking some bits here. Now, there's a quiz here that says, what are the 3 parameters that must be set on the high flow oxygen therapy device by the bedside provider? So could we spend 30 seconds and fill it in the chat box? 3 parameters that must be set on the high flow oxygen therapy device by the bedside provider. If you recall the video we watched on setting up, thank you, we're getting some responses. Flow rate. Yes. For some more responses. Temperature, we have flow rate, FiO2. Another participant said oxygen concentration. Temperature, We have someone oxygenation. No, I think that's okay. Flow rate, FiO2 temperature. Okay, thank you for those responses. I think we can go ahead. Okay, so okay, we're going to have a video that just shows, and really it's the flow rate, the FiO2, and the temperature, like we've previously said. Flow rate, you need to know exactly what the demand is, and how much the patient needs, and that will help in escalating or de-escalating. Temperature also to make it very comfortable for the patient and all the benefits of humidification, while the FiO2 is important since oxygenation is really the problem. So we'll just watch this video and just get some idea of the clinical application of high flow oxygen therapy. Dr. Datti, there's no audio. That's okay. Hello, Dr. Datti. Hello, can you hear me, please?
Yeah, we can hear you, Dr. Irene.
Okay, but I think the video isn't playing.
Yes, the video is stuck, Dr. Datti. Maybe you can stop sharing and start sharing again, and also click for the option of sharing sound.
So, well, I think while we wait for the video to come up, we had FiO2. We realized that with the high oxygen, we can get up to 100% of oxygen. So that's like one. So we can, it depends on how much was the patient on and what device you had. Usually should go to that same number or probably higher. Then based on the patient's respiratory rate, you actually know I need to go to a higher flow. There's some high flow oxygen therapy devices that can give you up to 60, and I'm sure there are newer ones that can give you a much higher flow rate. So you have that luxury of between 20 to about 60 and see how you can adjust them. Of course, you have to review your patient probably every 2 hours to see if you need to de-escalate or escalate, if the SpO2 improves, or in centers where you can have access to arterial blood gases, at least you can use that to check and see what the oxygenation is like. This is in patients where they're not hypercapnic, because remember, it's just oxygenation that is the benefit of high flow and the workup problem. Temperature, you set it usually 37, 37.5 to humidify, and of course for all our patients, we should actually check their temperatures also. So I think while we're still waiting, if there are questions, we can put them in the chat box and we can address it. I don't really want to move to the next one until prompted by our moderator. So Kevin, is it possible to start to see if you can share from your side?
Yes, Dr. Irene, I'm just finalizing here to reboot my device, and then in like 3 minutes I will share again. Okay. Apologies.
Okay, no problem. Then I think it's also important I know we're going to go ahead of, but of course we have to review our patients 2 hours. We see, do I need to up my FiO2? Do I need to take it down? The patient is getting better. And it's also important with the fact that we still have COVID on board, and I think with this third wave, we're having more patients, to realize that it's a high aerosol generating treatment modality. So it's quite important that we have our PPE, and Dr. Datti had mentioned it at the introduction. It's important we have our PPE, N95 face mask, because we're going to be the ones assessing these patients and adjusting. Of course, the ICU nurses can also adjust, the settings, but usually you want to do that and be sure that they're being stabilized with whatever settings they are comfortable with. So while we wait for that, do we think in the chat box we can write what the indications for high flow oxygen therapy? What clinical cases do you think? If you can put that in the chat box, the indications for high flow oxygen therapy. If you can put your answers in the chat box. Thank you. We can spend probably more than 30 seconds for this one while we wait. Indications for high flow oxygen therapy.
Dr. Irene, we are ready. I've already shared the screen now.
Okay, thank you very much. So we'll just continue with the video on the clinical application. Okay.
In the previous video, we talked a little bit about what high flow therapy is. In this video, we'll quickly highlight the clinical application of high flow oxygen therapy. We already discussed that high flow therapy is not a replacement for non-invasive ventilation because it is not capable of providing the same level of ventilatory support like NIV. In high flow therapy, for example, there is no inspiratory pressure setting, no PEEP or CPAP setting, no backup respiratory rate setting, no inspiratory time setting, no patient ventilatory alarms. You also cannot monitor the tidal volume, the IE ratio, and there are no loops or waveforms. You get the idea. NIV, on the other hand, can provide all of these. In fact, the only two main controls on high flow therapy are FiO2 and flow. Let's look at FiO2 first. This is typically adjusted to maintain adequate oxygenation. The FiO2 can be set from a level of 21% to a level of 100%. Usually, patients in acute respiratory distress who are on high flow may initially require a high level of FiO2 to maintain an appropriate saturation. Next is the flow setting. The flow is usually set to try to meet or exceed the patient's inspiratory flow demand. This is challenging because it's difficult to determine what the patient's inspiratory flow is. We learned in the previous video that at rest, when the patient isn't in respiratory distress, the typical inspiratory flow of an adult is around 20 to 30 liters per minute. But for patients in distress, their flow demand will likely be higher. So clinicians often titrate the flow according to the patient's respiratory rate. In other words, the faster the patient is breathing, the more flow they'll probably need. So if you're using the Vapotherm's precision flow device, the highest flow that you can set is 40 liters per minute. On other devices, like the Airvo 2, they can go as high as 60 liters per minute, and still others can go higher. So these two settings, the flow and FiO2, are the two settings available to the clinician to treat the patient in respiratory distress. If the respiratory rate or the CO2 on the arterial blood gas cannot be corrected or stabilized despite a relatively high flow rate setting, you may need to escalate to non-invasive ventilation or even intubation, depending on the severity of the hypercapnia. Likewise, if the pulse ox or the PaO2 on the arterial blood gas cannot be corrected and stabilized despite a relatively high FiO2 setting, then be prepared to escalate to non-invasive ventilation or even intubation, depending on the severity of the respiratory failure and the diagnosis of the patient. But whatever you do not delay escalation if the patient does not improve with high flow oxygen. Okay, now remember, because there are no patient alarms and data monitoring is not available on high flow oxygen devices, regular patient monitoring is critical. There is one more control in high flow therapy, and that's the temperature setting. To ensure that the high flow of oxygen is tolerable, heat and humidification should be provided. The exact appropriate temperature setting is debatable, and there currently exists no temperature standard. Some suggest to start at 37 degrees Celsius, Others suggest start lower, but the key point in temperature setting is to adjust the temperature based on patient comfort and tolerance. Which patients should high flow therapy be placed on? It's still a bit unclear, but we tend to see good outcomes in patients with what we call de novo hypoxemic respiratory failure. De novo hypoxemic respiratory failure is defined as significant hypoxemia but in the absence of chronic lung disease such as COPD. We also do not include the kind of respiratory failure that occurs in the immediate postoperative or post-extubation period. Remember, high flow therapy can deliver a high FiO2 at a high flow rate, so we anticipate it to be beneficial for hypoxemic patients. However, if a patient presents with acute hypercapnic respiratory failure, which is exhibited by an abnormally high CO2 and a corresponding abnormally low pH, then clinicians may want to consider an alternative form of intervention, such as NIV. Well, what about you? How have you seen high flow therapy used? Leave your comments below. I would love to read some of your responses.
All right, thank you very much, Irene, and thank you, Kevin, for that video. We apologize for that glitch in the communication, but we're still on course. We still have time to cover the remaining part of the session. So I think, Dr. Now that video sort of still revise those 3 parameters that you need to set when you are using this device. FiO2, and then you need active humidification, temperature and humidification, and then you need to set the flow. But then there are 2 messages there in that video that do not delay escalation of therapy, meaning if you need to go to move to another device or invasive oxygen therapy, you shouldn't delay that. And then monitoring is critical. What you can monitor here, like the video says, you don't have all those alarms, you don't have tardive volume, you can monitor all those that, but you can monitor the saturation of the patient and then other parameters. Now, so I think we've done that, the list. Irene, sorry, you're done with the indication for high flow oxygen because they were typing. I didn't see that. Do
We
you
didn't
want
get
to comment on that? Okay, there was no response. Oh, okay, fine. Okay, I think you can continue here to explain to them because these are as in the figure below there.
Okay.
Then we can move to the next segment. Thank you.
Okay. So we're talking about some of the indications for high flow oxygenation. Of course, the important one is when there's hypoxic respiratory failure, when there's an issue with oxygen delivery. Then high flow oxygen therapy is needed. I've also, with experience, I know some places will say no because based on here, they said conditional or no recommendation, but somewhere in some other studies quoted, you could also use it even pre-induction for a patient who you feel has a low functional residual capacity and will desaturate quite quickly when you paralyze. You can use the high flow oxygen therapy pre-intubation, so that at that period where patient is apneic, you have the passive oxygenation. And remember, it's high flow. You can go up to 50 liters, so that just helps a lot. And it's still the same premise in using it following extubation for patients who you feel like have a low FR, functional residual capacity. You feel they desaturate pretty quickly. So you can use that following extubation if you feel patient wasn't so clear-headed on extubation, and it's quite easy to use. Also, it can also be used in obese patients, of course, because they probably have some degree of obstructive sleep apnea. Although using their CPAP machine is really probably much better for obese patients, but it tends to be a bit more tolerable than the CPAP mask that you use, especially post-operatively. So it has also been found to be beneficial in these patients and these settings. But of course, most times it will be more of our patients who are hypoxic and are in respiratory failure that will tend to use them, especially in the intensive care setting.
Thank you very much, Irene. Let's move down. Let's scroll down, Kevin. So these are just resources. Okay,
Yes.
let's go.
Yeah, I think we've gone through the same.
Yeah.
Okay.
So want
Should I
to
continue, sir?
yeah. So let me call on Dr. Suleiman.
Yes.
Suleiman, I can tell you there's a question here. Which one of the following is incorrect regarding the parameters set by providers when delivering high flow oxygen therapy? Let's do this one before we move to the next, the NIPP.
Okay, thank you, Dr. Datti. As usual, I will give maybe this time around 15 seconds for people to respond. I think time is running out. We have A, providers can use respiratory rate to estimate the initial flow setting needed on the high flow oxygen therapy device. But please, we need to understand the question first. It says, which one of the following is incorrect? Which one of the following is incorrect regarding the parameters set by providers when delivering high flow oxygen therapy? So we said A, providers can use the respiratory rate to estimate the initial initial flow setting needed. Providers can directly measure the flow at which a patient is breathing and match their inspiratory flow demand on the high flow oxygen therapy device. C, the average inspiratory flow of an adult breathing at rest is approximately 20 to 30 liters per minute. D, the flow rate set on high flow oxygen therapy should attempt to meet or exceed the patient's inspiratory flow demand. E, respiratory flow demand increases during respiratory distress. So please quickly, our response, okay? Everybody said B. B, providers can directly measure the flow which a patient is breathing. Okay, so B. Okay, so I think, yes, you are all right. Among all the following options, the only one that is not correct is the ability to directly measure the flow at which the patient is breathing. If you can remember in the video, he specifically mentioned that that's difficult to do. But of course, we have a range of 20 to 30, which normal patients breathe at rest. So we use that to initiate our therapy as a guide. Please, let's move down. Okay, the next one is also a question which says, in which of the following scenarios would providers need to escalate care from high flow oxygen therapy to either NIPV or intubation with mechanical ventilation? And the options are A, respiratory rate does not correct or stabilize despite receiving high flow rate on HFOT device. Do we need to escalate? The patient partial pressure of carbon dioxide remains elevated or worsens on arterial blood gas analysis despite receiving high flow rate on HFO2 device. HFOT device, do we need to escalate? Then C, the SpO2 does not correct or stabilize despite receiving high FiO2 on the HFOT device. And then D, the PaO2, that's the partial arterial pressure of oxygen, does not correct or stabilize despite receiving high FiO2 on the HFOT device. Then E, all of the above. I think we have received some, okay, I'm yet to receive any answer. Okay, one said B, that when the patient's partial pressure of carbon dioxide remains elevated or worsens.
Okay.
So if you look at the question, it's saying, when do you need to escalate? I think I will just go ahead and, okay, continue with the discussion. Okay, yes, I've received EEE, which I think is correct. If you look at all the options here, okay, shows that patient is not improving, or rather is deteriorating. And whenever you know,
Your interior of your home is a self-reflection of who you are as a
and the patient is not improving, or is rather deteriorating, there is a need to escalate your therapy. So the answer is E. Look at all the options. There are features of deterioration. So please, let's move down. Let's scroll down. Okay. The next thing is, what is ROX index, and how can it help clinical providers? ROX index, in simple terms, is the SpO2 divided by the FiO2. So of course, it will give you a value which has a unit of percentage per respiratory rate, and usually it is used, to show whether a patient may require intubation, whether you're achieving, what you need to achieve. And it is said that once you have a value of more than 4.8 for at the 2 hours after commencement of therapy, after 6 hours of commencement of therapy, and after 12 hours of commencement of therapy, usually this patient is unlikely to require intubation. It's likely to do well on high flow oxygen therapy. So that is the clinical relevance of ROX. However, studies are ongoing to see how it affects, things like mortality, hospital stay, and other things, in order to see whether it should actually be incorporated in the clinical setting. So those are the discussions going on about this ROX index.
Yeah, thank you very much, Suleiman. Yeah, thank you. We need to move on because of time. Like you said, the ROX index, you can find it there. It is SpO2 or FiO2, the ratio of that to respiratory rate. And there's a figure there, usually greater or equals to 4.88. That is the figure you should use whether to intubate or not. Now let's move to the update. Mr. G remains on the high flow oxygen therapy with the following settings: temperature beginning to normalize 37 degrees Celsius, an FiO2 of 100%, flow of 60 liters per minute. After 2 days of initial improvement, his SpO2 is 90%, but he is more tachypnic now with a respiratory rate of 35 beats per minute, and he appears to be fatigued, and his arterial blood gas analysis reveals the following: a pH is low, 7.27. He has a PaCO2 of 58 millimeters of mercury, and then PaO2 60 millimeters of mercury. The bedside team desires to try NIPPV. So Irene, I need to defer to you alone again because of the experience you have at your isolation center in this NIPPV. So as a reminder, still, this is reminding us that when you are doing NIPPV, you will need to consider the PPE for the patient and also for the provider. So let's go down, and Irene, take us quickly through this bit, and that will be the last segment.
Okay. Thank you very much, Dr. Datti. Our practice change here objectives based on non-invasive positive pressure ventilation. We need to list the indications for NIV or NIPPV, the benefits and complications. If we scroll down, there's what's the difference between NIV, NIPPV, CPAP, and BiPAP. NIV is non-invasive ventilation, basically, that is it. Then you have the non-invasive positive pressure ventilation, where there's some positive pressure applied. CPAP is continuous positive airway pressure. So there's a continuous positive pressure which happens for all of us as we breathe spontaneously. It's normal. Then, of course, for some patients, we need to include that, but it just keeps the alveoli open throughout. Then there's the BiPAP, bi-level positive airway pressure. This gives the pressure at inspiration and expiration. In some machines, you can actually give different values for what the inspiratory pressure should be at the end and the expiratory pressure. While for some, it just gives the same pressure, both at inspiration and expiration. Now, in which kind of patients do we use NIV? Of course, for patients who are not improving, if they've been on high flow oxygen therapy and they aren't improving, their SpO2 is dropping, not improving as we want, we calculate the ROS index is less than 5, then you need to escalate, and NIV is the next thing to move. Patients with chronic respiratory issues like COPD, neuromuscular diseases, patients with obstructive sleep apnea, obesity, hyperventilation syndrome. You all add that, but those are long term. But because this this webinar is based on COVID and all of that, they're not really going to talk about chronic respiratory issues. But patients who are not improving, if you've tried high flow oxygen therapy and you're having deranged blood gases. I don't know. Do we have time for the video? Oh.
Yes, we should watch the video.
Okay. I'll just let us watch so I don't talk so much. And the important thing is getting a good fit for the mask, and patient has to be comfortable with it. If patient is uncomfortable because it's claustrophobic, then you have to think. Well, let's listen to the video. Sorry.
CPAP, continuous positive airway pressure, and non-invasive ventilation, also known as BiPAP, biphasic positive airway pressure. CPAP is a way of keeping the pressure positive in a spontaneously breathing patient's lungs. This positive pressure helps keep the smaller airways and alveoli open, which allows for additional gas exchange to take place by recruiting areas of a lung that might otherwise have collapsed down. A tight mask is applied to the patient's face to create a seal. Air and oxygen now flow through a circuit attached to the mask at high flow. The patient exhales through a valve which closes when the desired pressure is achieved. This pressure created by the valve is known as PEEP, positive end expiratory pressure. It's this that leaves the pressure in the patient's lungs at the end of expiration. There are several tight-fitting masks that can be used: oral masks, naso masks, full face masks, and CPAP hoods. CPAP has been shown to be particularly useful in acute cardiogenic pulmonary edema and congestive heart failure, where, in simple terms, the positive pressure created helps push the fluid out of the lungs and into the circulation and prevents further fluid coming back into the lungs. It could also be used for pneumonia, sleep apnea, and atelectasis. So what is non-invasive ventilation? Sometimes just keeping the alveoli open isn't enough, especially if the patient develops type 2 respiratory failure and starts to retain carbon dioxide. Think of non-invasive ventilation as CPAP with added zing. Non-invasive ventilation is used to increase the size of each breath taken by the patient. It gives an assisted push behind the breath which increases its size and thus reduces carbon dioxide levels by blowing off CO2. It seems to be most useful in conditions such as exacerbation of COPD and post-extubation on ITU. Some success has been reported with asthma patients as well as certain other respiratory conditions where there may be reluctance to sedate, intubate and ventilate a patient due to existing risk factors. So how does non-invasive ventilation work? As with CPAP, a tight-fitting mask is fitted to the patient's face, but this time the patient breathes through a mechanical ventilator. On the ventilator, two pressures are set. Firstly, the positive end expiratory pressure, PEEP, similar to that used in CPAP. As before, this pressure helps preventing the alveoli from collapsing. Secondly, the pressure that creates the push. This is the inspiratory pressure, which increases the size of each breath or tidal volume. The bigger the pressure, the bigger the push, the bigger the tidal volume. So let's assume that we set the PEEP at 10 centimeters of water. The pressure in the patient's lungs will not drop below this level. It's now the baseline pressure, if you like. Now assume we set the inspiratory pressure at 15 centimeters of water. Note that the inspiratory pressure is added on top of the PEEP. As the patient takes the breath, it causes the ventilator to initiate. It now increases the pressure until the inspiratory pressure is achieved. Once the inspiratory pressure has been reached, the expiratory valve opens, the pressure begins to fall, and the patient exhales passively until the pressure drops back to the PEEP level, where the valve closes to maintain the pressure. The inspiratory pressure can be adjusted until the desired tidal volume has been achieved, usually about 6 to 8 mils per kilogram. In addition to the pressures in both non-invasive ventilation and CPAP, oxygen levels must be set. For various reasons, this is frequently referred to as the FiO2, or fraction of inspired oxygen. The FiO2 is expressed as a fraction, so that 100% oxygen is expressed as an FiO2 of 1 and 21% oxygen is expressed as an FiO2 of 0.21. So, to summarise, CPAP uses high flow and positive pressure at the end of expiration to keep the alveoli open and improves oxygenation. Non-invasive ventilation gives a push behind each breath to increase the size of the tidal volume, which in turn lowers carbon dioxide levels. So that's it, a very basic overview of CPAP and non-invasive ventilation in under 5 minutes.
Thank you.
Yeah, thank you very much. That was a very short but powerful video there. So I think because we are running short of time, just want to say there are 2 conditions leading to acute respiratory failure in adult patients that have very strong evidence of benefit from NIPPV. You're asking me what are they, and this, you down there, you see acute exacerbation of COPD. These are the things that you need to benefit from: available, prepare, reduce mortality, reduce rates of intubation, reduce length of stay of hospital stay. And then on the other, they have acute cardiogenic pulmonary edema. Let's scroll down. So here you need to list contraindications to NIPPV, and absolute contraindications are urgent need for intubation and mechanical ventilation. So you don't even venture into that to say you want to start NIPPV. There are relative contraindications, facial or neurologic injury, trauma, or deformities. Then you have upper GI bleeding or active emesis, encephalopathy, and the need for prolonged mechanical ventilation, and the inability to cooperate or protect the airway or clear secretions when you have obstruction of the airway, so you don't venture into that. Let's go down. So Mr. G is reported to have been placed on NIPPV for 1 hour with pressure support, ventilation of 15 centimeters of water, and a PEEP of 5. His FiO2 is set to 100%. His respiratory rate remains at 35 breaths per minute. He appears fatigued, is slumped over in the bed, and arouses only with shaking. So what is the appropriate next step in Mr. G's care? Because of time, say that Mr. G will probably now need invasive therapy. He needs to be intubated. You can't continue with the NIV because you've reached, you can see he's fatigued and he's slumped with all that setting. Well, I want to thank everybody. Before we go, I'd like to close with this quote. Okay, these are materials you can all get from the Learning Resource Center. Now, if you scroll down, yeah. So the best way to find yourself is to lose yourself in the service of others. This is a quote, great quote by Mahatma Gandhi. So I want to thank all our participants and our great co-panelists, Dr. Irene, Musa Suleiman, Salim, and Embu. We thank you very much for sharing your insights and experience with us here. Over to you, Kevin.
Thank you.
Thank you, Dr. Datti. Thanks to all the panelists and the participants as well. We have now reached the end of our session today. And I would just like to apologize for the breakage that we had in the middle of the session. We'll try to improve next time. So I would like to share a little bit of my screen here. So you can visit the Learning Resource Center to access the presentation slides and recordings. Also, you can have additional resources such as quiz, exercise, and videos. And we will share the link to the LRC in our groups. And also the recording of this session will be shared after the session by email. You can join our WhatsApp group by scanning this QR code here so that you can be updated and given information about the sessions, or you can message assist at this number below. So I would like to thank you, and please be reminded of session 9, which is going to be held on September 30th, 2021, and we are going to be discussing defining ARDS. If you have any questions, you can send them through the email at echo@assistinternational.org. Thank you so much, and see you in session 9 in the coming month. Echo India team, thank you for supporting us on this session. I think we can close the session now.
Thank you so much.